All right, so let's talk about management. So we've talked about diagnosis and recognition, but once you find these patients, what are you going to do about them? So I want to talk about two types of patient. One is an acute patient who's presenting with a very high ammonia, but the thing we also overlook is how do we follow these patients long term? How do we manage them over years, decades, with the things we do? The cycle, as we talked about before, takes ammonia, makes it into urea. Something to remember, though, is different tissues use the urea cycle for different things. The liver uses it primarily as toxin clearance. All of the enzymes are present. That's the purpose. In the gut, however, the urea cycle stops at arginase. So the gut actually exports citrulline and arginine. So the biosynthetic availability of arginine comes from there, and you have to remember that with treatment. We have four common things, so I will stop and say that the opinions I give are based on my clinical practice, also my participation in the American Urea Cycle Consortium and what I've learned from my colleagues there. But there is a difference between evidence-based medicine and what we call eminence-based medicine. Some of these are opinions. They're the best I can come up with. I will try to separate the two. We focus on four things in treating a urea cycle patient. The key in the top is neuroprotection. Above all else, protect the brain. The long-term consequences of this disease are most severe for the brain. Our patients suffer more from neurocognitive defects than almost anything else. We use three things to do that. One of the most important, which you'll hear about later, is nutritional management. This is something in the early days we often overlooked. We thought restrict the protein, go forward and be fine. What we found now that the nutritional management of these patients is much more sophisticated than that. Pharmacology, we have some medications we can use. We have some medications we should not use when we treat these patients. And then for the acute patient, we come down to physical removal, such as dialysis. When you first find a patient with a very high ammonia level, there's an organizational process you need to do. You have to get your team together. You have to pull in the surgeons to place the lines, the pharmacy to get the drugs, the laboratory to measure the ammonias, the nutritionist to come up with the management of the calories. There's a rule of nature. All urea cycle patients present at 4 o'clock on Friday evening, just before everyone or after everyone has gone home. So one thing I always recommend is identify the members of your team before your patient comes in. Make sure you know who you're going to call. Have a list. I'm a big believer in checklists for this. So we'll talk a little bit about emergency management and stabilization. Many of you live in countries where there are wide geographic distances. The state I originally worked in was many, many, many kilometers across. Almost all of my patients came in from remote sites where there were not so many medicines, there was not so much expertise. So one of the things you want to work out is how does that patient become stabilized to be transported to your unit. We'll talk a little bit about bulk ammonia removal or dialysis, stabilization, and follow-through. Emergency management, what we recommend for the physician in the field, the clinic in the field, is first fluids. Fluids with glucose in them. Not too much, not too little. The patient has a swollen brain. You don't want to give them massive amounts of fluid, but almost all of these patients are dehydrated to a certain degree because as their level of consciousness decreases, they start drinking and they will often become dehydrated. Antibiotics. All of these patients typically have had a septic workup and are on antibiotics. We recommend continuing the antibiotics because the process of treating them in the hospital, they're going to have numerous procedures, numerous breaches of their skin barrier, and they're so stressed that anything remotely like a bacterial infection can kill them very quickly. So we keep antibiotics going for these patients. Know how you're going to transport these patients, whether it is by air, whether it is by ground. If that's impossible, then you have to become very creative in how you manage the patient locally. Have them stop protein there. Now I'm going to come back and say you're going to restart the protein very quickly, but if the patient presents in the field, ask them to stop the dietary sources of protein. The other thing is it's good to have a large bore catheter for venous access. Now, there's an upside and a downside. Many of the outside centers, when they are trying to place that, will use up all of your vessels because they have trouble getting the catheter placed. So it's a balance. Don't have them use up all your large veins because you're going to need those for treatment, but if they can get a large catheter in, that's particularly good during transport. You can give fluids if you need to give medications. One of the keys is to protect the kidneys. Make sure there is enough vascular blood flow, that they're not going to go into renal failure, because the drug treatment for this disease and many of the other aspects of it require kidney function for long term. So protecting the kidneys is always worthwhile. Some of these patients will have fluctuations in their blood pressure, and that needs to be supported. When do you dialyze? Clinical judgment is very important here. Typically, there's not a magic number of ammonia when you say, dialyze, don't dialyze. You need to look at how rapidly the patient's cognition has progressed. Are they in a coma? Has this happened quickly? And then you need to use dialysis. What does it simply do? Ammonia distributes to the water volume of the body, so it's everywhere in the body. Dialysis is very effective at removing ammonia. It crosses dialysis membranes easily. It is directly related to the flow rate of the dialysis. That's why you will often need those very big catheters. You also will need the help of your nephrology team or your dialysis team, because it is very tricky to do dialysis on a small child, to control the volumes properly, to make sure the blood pressure does not fluctuate too much, and to use the proper fluid mix. We don't recommend peritoneal dialysis. We pretty much stopped doing this in the States, mainly because the volumes that you can do in the peritoneal cavity, the exchanges, are so small that you cannot clear that much ammonia. There's significant risk to peritoneal dialysis for infection. And also, now that we see that the nutritional management is so much more important, you delay access and use of the intestine, because you can't really feed a child while you're doing peritoneal dialysis. We'll use some different versions of hemofiltration. Your teams that are doing cardiac surgery will often have the most sophisticated pumps for doing this, but also your nephrologist will know these as well. So there are many different forms of dialysis. Almost all of them depend upon the flow rates. The faster the flow rate and the counter current, the more ammonia you can remove. Neuroprotection. This is really one of the keys to the game. So when the brain swells and nutrient delivery decreases, that means that the brain is susceptible to damage. With a decrease of delivery of oxygen, glucose, and other nutrients, at the same time the patient is being stressed, that can lead to more cell death. So one of the things we've looked at is ways to protect the brain during this time period. One thing you can do is cooling. If the patient has dialysis, you can actually use the dialysis circuit to cool the patient. Also, most neonatal intensive care units now will have the ability to cool a patient. They'll have cooling blankets, cooling caps. They use them to treat patients with hypoxia in the newborn period. This also seems to work for patients in acute hyperammonemic crisis. We will also use medical methods to suppress neural function as well. We will use pentobarbital to put the patient into a coma. Now, this is a balance. If you put the patient into a pentobarbital or drug coma, you lose all of your markers of how that patient is doing cognitively, because they're completely out. So you're going to lose some of your clinical markers, but you may have a really nice protection of the brain. It just means you may have to wait a few days to see how the patient is going to do. Dietary intervention. Dr. McLeod is going to speak about this next. She is our biochemical nutritionist. But this has been the biggest change in the field in my career. When I started, we restricted nitrogen until the ammonia returned to normal. It probably ended up being one of the worst things we could have done, because what we found is if you restrict essential amino acids for these patients, they will catabolize their own protein to replace that. This will drive the ammonia up, and you'll end up with a very long period of ammonia elevation. What we found now is that we aggressively replace essential amino acids, often within 24 hours for these patients. We'll later introduce natural protein, but we've actually found that introducing the essential amino acids can help drive the ammonia down by stimulating anabolism or protein production. So this has actually been a very positive thing that we found, and actually helps us stabilize our patients very quickly. Those of you who have managed these patients acutely know about what we used to call the bump. After you've dialyzed the patient, brought the ammonia down very quickly, about 12 to 24 hours after you stop that, the ammonia rises back up. What we found is by aggressively managing the nutrition and reversing the catabolic process, we can oftentimes avoid that bump or the secondary rise in ammonia. One thing that is used in some centers is a glucose insulin drip. This is a very tricky way to block catabolism. Depending on the day of the week you ask me whether I'm a fan of this or not, I'll change. Because it can get out of control very quickly. You're giving large amounts of glucose with an insulin drip, but if one gets ahead of the other, you can either make hypoglycemia, which is very dangerous for these patients, or hyperglycemia, which can also be very dangerous for these patients. So if you have an experienced team who knows how to manage a glucose insulin drip, it may be useful, but if you don't, I would avoid it. Ammonia and glutamine, those are the two things we want to attack. So ammonia we attack by physical removal by dialysis, removing some of the nitrogen input. Glutamine's a little bit of a different matter. So what's our toolbox of pharmacology for these drugs? Well, probably the oldest we use are phenylacetate and benzoate. And I'll show you a little bit about the chemistry on those. They've been around for a long time. One is very expensive, one is not so expensive. One has 2 moles of nitrogen, one has 1 mole of nitrogen. One of the newer compounds we have, though, is carbonyl glutamate. It's a synthetic analog of N-acetyl glutamate, the cofactor for the first enzyme in the pathway. Now, the patients who have a primary defect in N-acetyl glutamate synthase are fairly rare. We've only identified about 6 to 8 in the United States, but we've also found that about 20% of our patients with CPS1 deficiency will respond. So reflexively now, when we have a new patient with what we think is a urea cycle disorder, before we have a diagnosis, we'll start them on the carbonyl glutamate. If they respond beautifully, we'll keep it on. If it doesn't seem to affect the course, or we're able to diagnose that they have a different enzyme defect, we'll take it off. But the benefit of that when it works is so great, it's probably worth the try. The other thing to remember is downstream. You know, when you put the block in the metabolic pathway, you have a buildup of substrate, but you also have a decrease in product. You have to be able to replace the arginine and citrulline that these patients can't make. The exception, of course, is arginase deficiency, the last defect in the cycle, but it's not so common. So you have to be able to replace those. Otherwise, what will happen? The body will become catabolic. They will break down their own protein, and you'll always be chasing those patients. The theory of the pharmacologic management is we use the carbaglu early on. We start nitrogen scavenging drugs early. One kind of, let's see, how would I say this? This is sort of the attitude we will use on these patients in the States. I've seen some centers, they will do one thing at a time. Well, we'll see if this works. If that fails, then we add that. If that fails, then we add that. These patients don't have that kind of time. If I had 10 drugs that would remove the nitrogen and help get the ammonia down, I'd use all 10 at the same time. So I use the ones that I have access to. So when we have a new hyperammonemic patient, we hit them with phenylacetate, we hit them with benzoate, we hit them with arginine, we hit them with dialysis, we hit them with nutritional management, we hit them with carbaglu, and then we sort it out going forward, because most of our patients, although sometimes with family history, yes, but most of our patients don't have a label saying, I have ornithine transcarbamylase deficiency, or I have argininosuccinic acid synthetase deficiency. We have to figure that part out as we go along. So we hit them very hard early, and then we sort it out going forward. The other thing we do is we do continue the antibiotics. As I said, these patients are very ill. They're being instrumented. It's just not a bad idea. We will end up using blood pressure or medications to maintain blood pressure, because we're going to need the kidneys when we've done the acute treatment of this patient. The two drugs we use primarily, benzoate and phenylacetate. Benzoate combines with glycine to make hippurate, which is rapidly excreted by the kidneys and also dialyzes very easily out of the body. Glycine is not one of the primary toxins in urea cycle disorders, but you can use this as a nitrogen trap. The body will make glycine in every cell in it. By pulling glycine out of the system, you can force the body to use excess nitrogen to replace it. Phenylacetate will bind with glutamine to make phenacetyl glutamine. This has two benefits. One, it's 2 moles of nitrogen for every mole of drug. So glycine is 1 mole per mole, phenylacetate is 2 moles, so you can get twice the nitrogen clearance. But the other is there is definite evidence that glutamine is one of the neurotoxins that we have to deal with in urea cycle patients, particularly in the central nervous system. So by pulling glutamine out of the system, we think not only do we get the benefit of increased molar clearance, but we also get the benefit of removing one of the primary toxins. So phenylacetate and phenylbutyrate, the prodrug, and a triphenylbutyrate glycerol compound have become our frontline drugs in the United States. But in the acute management, we use both. Well, like I said, if I had 4 more or 10 more drugs, I'd probably use those 2 if I could pull extra nitrogen out. The benefits of the 2 versus their toxicities: for phenylbutyrate, phenylacetate, 2 moles versus 1 mole for benzoate. Cost is an issue. Cost for phenylbutyrate, phenylacetate is high. Benzoate's the most commonly used food preservative in the planet. You can buy it by the train car load full. The amino acids cleared is glutamine, which we think has CNS toxicity. Glycine, on the other hand. The toxicity at overdose, which one thing, if I can urge you, if you are caring for these patients, and I know the experienced physicians here know this already, this is a type of case where you have to be at the bedside to manage this patient. You can't call these in, because you have to check the drug doses, you have to check the IV fluids, you have to check what's going into these patients, because little bitty mistakes can have huge impacts on these patients. If you do everything right, the outcome can be excellent. If you don't, it's not so good. But for the last 10 to 15 years, our expectation is that a patient who presents with a new urea cycle defect, assuming that we're within about the first day of them going into a hyperammonemic coma, is going to have a normal testing IQ 5 years later. We consider anything less than that a failure. So we have very high standards now for what we're trying to do. So the toxicity for phenylacetate is more like a salicylate poisoning. It almost actually can look like hyperammonemia. For benzoate, it's renal toxicity. Very high dose exposure to the kidneys over time will result in nephrotoxicity. All right. For your downstream replacement, if you have what we call a upper cycle defect, CPS, OTC, N-acetyl glutamate synthase, citrulline is the recommended replacement. Why? First off, it's a neutral amino acid. It's not going to do a lot to the gut. If you start dumping arginine into the gut, it can stimulate a number of different things going on, but also you get the benefit of pulling some aspartate into the pathway. Whether that's enough to have much scavenging effect is a little difficult to say, but we do think that's beneficial. If you have a lower cycle defect in ASS or ASLD, then you want to use arginine to drive the cycle back around. Now, the thing to remember is you have to be careful with arginine. If you get the levels very, very high, it also has a neurotoxic effect. You get a spastic paraplegia from exposure to very high levels of arginine over a long period of time. The other thing that we have found is that we are pretty sure argininosuccinate is also a hepatotoxin. It may also be a neurotoxin as well. So previously, you'll see that we used very high levels of arginine in these patients, upwards of 500 milligrams per kilogram over time to suppress ammonia by driving it back around to argininosuccinate. At Baylor University, Brendan Lee and his team did a randomized trial on this, looking at high-dose arginine and low-dose arginine and hepatic damage. To summarize it, they found that low-dose arginine had a much less of an effect on hepatic damage. The livers actually looked much better on biopsy, on ultrasound, and the enzymes were much lower. And they used the other drugs like phenylbutyrate and triglyceryl phenylbutyrate, tributyrate, the glycerol conjugate. And that worked very nicely to keep the ammonia down. So they didn't have extra hyperammonemia, and it was easier on the liver. So we learn as we go. So I tend to clinically group the patients. I won't spend a lot of time because we're a little pressed for time right now, but we tend to call them high cycle defects, those inside the mitochondria, CPS, OTC. Then sort of low cycle defects, ASS and ASL. The transporter defects, of which we have both in citrin and then in HHH, we tend to classify a little differently, but use some of the same techniques. And then we have our patients who are later onset. And we tend to take different treatment strategies with all of these. Discharge planning is probably the thing in my part of the world, we do the worst. Because, we've had the excitement of taking that hyperammonemic patient, stabilizing them, getting their ammonia down, and then we get bored and want to go do something else. But discharge planning is what will keep these patients alive. You need social work involved to make sure they have access to all the supplies they need for medications, everything else. You're going to have to get the infant formulas in beforehand. And we actually have a policy. We will not send the patient home until all of the compounds that patient's going to need are in hand. The other thing we do is we use gastrostomy tubes preemptively. We don't wait for the patient to fail dietary therapy or coming back in. If they present as a newborn with a urea cycle defect, we do the same with our organic acidemias. We put a gastrostomy tube in before they discharge. We found that cuts our admission rate almost in half. These patients, you can manage them much more easily. They do a little throwing up at home. They don't want to eat. No problem. You put it in the gastrostomy tube, and you can actually maintain their caloric intake. We always do a treatment emergency letter. I assume you do the same. And we also will start a transplant workup. When I started in the field in the 1980s, gene therapy was 5 years away, as it was in the year 2000, 2010, 2015, and it's still 5 years away, maybe even more than that now. So we use poor man's gene therapy. So we do liver transplant. What we do is we'll maximally stabilize these patients. If it looks like they have a mutation that is going to result in almost no activity, we'll either try to wait until they're 10 kilograms to transplant them, but if they're unstable, we'll transplant them even sooner. Now, you're trading one disease for another. Transplant has its own complications, and surgery in a small baby, the microsurgical techniques to match up the bile ducts are not perfect. But the risk of that versus the risk of an overwhelming hyperammonemia and further brain damage, we feel is a legitimate trade-off. So until gene therapy comes along and fixes all this and puts us all out of a job, which I wouldn't mind, we're using liver transplant pretty aggressively. All right. So some of the rationales: avoid catabolism. Aaron's going to talk about this a little bit more, but do everything you can to keep these children from breaking down their own protein. We use the scavenging drugs. We use phenylbutyrate because for at least in our experience, it works better. The Japanese data is all based on the use of only benzoate because phenylbutyrate was a banned substance in Japan. When we did a head-to-head comparison of using phenylbutyrate in the patients versus benzoate, we got better outcomes there, and that's just kind of where our data pool lies right now. All right. We talked about citrulline and arginine. Like I said, I'm going to try to get us back on time a little bit. Treatment, we talked about transplant. What's new coming along? Gene therapy, I'm sure it's 5 years away from now. Anabolic steroids. So we are taking a page from the baseball world where they use steroids to build up muscles and things. And one of the things we're looking at is, can we use anabolic steroids to suppress catabolism in patients and actually promote nitrogen removal by building up new protein? One of the other things that's come to light is that the gut plays a major role. The bacteria in the gut, particularly in a low-protein diet situation, will overproduce urease, which will break up whatever little urea the patient is making, converting it back into ammonia. There are actually already FDA-approved urease inhibitors. They were developed for treating ulcers, and we're looking at the use of those in patients with mild or partial urea cycle defects to see if that will help. There's now some new work in the adult liver field where they have identified bacterial strains and cultures that will overconsume nitrogen, so a way to scavenge nitrogen by using different types of gut bacteria. And I'm thinking I should be just over 20 minutes, so I'll call it quits there, and then we'll get Dr. McLeod on next. Thank you very much.